Hello, I'm Andrew Brenner with UT Health San Antonio and Texas Oncology Austin. We're here with Dr. Carey Anders with Duke University Medical Center, who was the moderator for this education session, Coordination of Care for Brain Metastases. Dr. Anders, a couple questions. I think the first one is a recurrent theme for the education session was the importance of multidisciplinary care and integrating different providers into the ideal management. Can you comment on that a little bit?
Sure. No. So I think, one of the main themes of our session was how multidisciplinary the care of our patients with brain metastasis truly is. And in fact, it's really part and parcel of what we do every day. There's not one physician that takes care of patients with brain metastasis. It's really a group of individuals centered around the patient, the systemic therapist and the medical oncology or neuro-oncology team, the local therapist and radiation oncology and neurosurgery. And then very important are our palliative care colleagues who can really help our patients with symptom management, goals, and end-of-life care. Yeah.
So, and then another big change that we've seen over the last few years in terms of management of brain metastases, especially for breast cancer patients, is the availability of new CNS active agents.
Yeah.
We have tucatinib now, and the addition of and HER2 has also made a difference. Can you comment, has that made a change in terms of how local management is done? Do you see that providers at your center or others are delaying doing SRS to use CNS active regimens? How have you seen the change in the last couple of years?
Yeah, no, absolutely. I think we've been very blessed by the emergence of several, not just one, but several agents with CNS activity. Historically, patients with brain metastasis were excluded from clinical trials, and now we're seeing trials specifically devoted to our patients with brain metastasis. So it really has continued to emphasize this theme of multidisciplinary management. It's, in the past, radiation or neurosurgical resection had always been the first line of attack. And now we're really integrating in systemic therapies even before radiation in select cases where patients present with small lesions, asymptomatic lesions. So I think this has really changed our paradigm and really speaks to the multidisciplinary nature.
Yeah, and I'm sure it will keep evolving as we get more agents into the clinic.
Absolutely.
So speaking of new agents and CNS studies, the HER2 CLIMB-02 was presented yesterday, and so that is one that allowed patients with active brain metastases to participate, as did HER2 CLIMB, the first with the capecitabine and trastuzumab. Can you comment a little bit about HER2 CLIMB-02 and then how you see this changing in terms of generally management of patients with HER2 positive metastatic breast cancer, and particularly brain mets?
Sure. I think we're still wrapping our head around the data and really trying to determine how we're going to sequence these therapies. I think we do have trastuzumab deruxtecan as a very viable option for both stable and progressive brain metastasis. From the tucatinib perspective, I think this gives us another backbone. And I think, one of the questions I'm really grappling with or really thinking a lot about is perhaps tucatinib needs to become more of a maintenance therapy for our patients with CNS disease. So you could envision a patient who either receives the capecitabine trastuzumab backbone with tucatinib at a progression event, then transitioning over to TDM1 or vice versa. Now, of course, we don't have the data for that yet, but we do have the history of trastuzumab helping our patients in subsequent lines. So that's one thing I'm thinking about. The other thing is just the sheer pill burden of the HER2 CLIMB-01 regimen, and many of our patients with brain metastasis are challenged with neurocognitive impact. So could the TDM1 every 3 weeks be an alternative to having to manage so many pills at home? So I think it gives us another option, and how exactly we're going to integrate it, I think is going to remain to be seen as we start using the regimen in real time.
Yeah, it's going to be exciting, especially to see some of the other secondary endpoints, such as intracranial response rates and things like that. So looking forward to seeing that, and hopefully it will be a good additional option, especially non-traditional chemotherapy with this loaded backbone. So thank you again so much for your time. It's good to see you.
Thank you. You too.